Hello everyone. Um, Today we will be talking about the image analysis for the lumbar spine. So let's get started. Image analysis guidelines for the AP lumbar spine state that the psoas muscles should be demonstrated within the projection. The spinous processes are aligned with the midline of the vertebral bodies with equal distances from the pedicles to the spinous processes on both sides. The sacrum and coccyx should be centered within the inlet pelvis. The vertebral disc spaces should be demonstrated as open, intervertebral, sorry. The vertebral body are seen without distortion. The long axis of the lumbar column should be aligned with the long axis of the exposure field. So we don't want to see the patient cattywampus on the image. The L3 vertebra is at the center of the exposure field. This occurs if you are performing a lumbar examination only. But in most cases, you will be performing a lumbosacral examination. Can't speak today, I'm sorry. So therefore, L4 will be demonstrated at the center of the exposure field. Further image analysis guidelines also indicate that the area from the lower thoracic vertebra to the sacrum is clearly demonstrated. The SI joint should be demonstrated equidistant from the vertebral column, and there should be no artifacts across the abdomen. So that means please remove pants or elastic wear or any jewelry that may be obscuring our area of interest here. You can see I have listed the image analysis guidelines for your review. So let's talk about rotation and how to identify it in an AP projection of the L-spine. Rotation in the spinous processes tend to move away from the midline of the spinal column and closer to the pedicles on one side and away from the corresponding pedicles on the opposite side. This results in a difference in distances between the spinous processes and the pedicles, where they should be equidistant in a true AP projection. The side which the spinous processes rotate up to demonstrates the side that is actually further away from the IR, meaning that side is actually up. So in this projection, you can see that the spinous processes are closer to the right side, meaning that the patient is actually in an LPO projection and their left side is positioned closer to the IR. Now, when looking at rotation in the distal or lower lumbar region, you can evaluate that by utilizing the sacrum and coccyx position within the pelvic inlet. If there's no rotation present, then the sacrum and coccyx will be demonstrated centered within the pelvic inlet. On rotation, however, the sacrum and coccyx tend to rotate towards the side of the pelvic inlet positioned further away, or the side that is positioned up. So again, in this image, the sacrum and coccyx is positioned more towards the right. That means the patient's right side is higher than the left, and the patient's in an LPO projection. You can also utilize your iliac crests. Typically when one crest is elongated than the other, then the side that is elongated is typically the side that's down. When the side that's foreshortened is typically the side that's up. Looking at this practice analysis, we can see by utilizing our tools that we just learned that the spinous processes here are somewhat closer to the left side, okay? You can see that they're typically in the alignment on this outer edge rather than down the middle of the spine. And it means that the spinous processes are narrower on that right side. Elongated on that right side, and the space between the left side is more narrow. This means that the patient is rotated towards the right side. In order to correct this, we need to rotate that patient back towards the left side so that we can appropriately align those spinous processes down the midline of the spine and ensure that the mid-coronal plane is parallel with the IR. So let's move on to the AP oblique projections of the L spine. AP oblique lumbar vertebra image analysis guidelines state that the superior and inferior articular processes should be demonstrated in profile. The zygapophyseal joints are demonstrated open and uniformly visible through the vertebral bodies. The pedicles are seen halfway between the midpoint of the vertebral bodies. The third lumbar vertebra is at the center of the exposure field. The 12th thoracic vertebra, 1st through 5th lumbar vertebra, 1st and 2nd sacral segments, and the sacroiliac joints are included within the exposure field. Additionally, the vertebral column should be parallel with the tabletop IR so that the T12 to L1 and L1 to L2 intervertebral joint spaces remain open. So make sure that you have that patient's vertebral column parallel to keep those joint spaces open. In the presentation, I have placed the image analysis guidelines here so that you can review at your leisure. Let's talk about the Scotty dog and how to determine your accurate lumbar obliquity for an AP oblique projection. The accuracy of a AP oblique projection is often judged utilizing the 5 Scotty dogs stacked upon each other. As you can see in this image here, this is an accurately positioned oblique lumbar vertebra with the Scotty dog parts outlined and labeled. It should be noted that the Scotty dogs can be identified even on oblique projections that have been attained with excessive or less than adequate obliquity. So in order to judge the actual openness of each zygapophyseal joint, you need to utilize that to determine whether the lumbar uh, vertebra has been adequately rotated. Meaning, look at your zygapophyseal joints. If they are uniformly open from L1 to L5, then you should be at the correct obliquity. So let's move on to talk about insufficient vertebral obliquity. Insufficient vertebral obliquity, or not enough obliquity, where less than 45 degrees, is indicated if the lumbar vertebra is in a position that the superior and inferior articular processes, meaning the ear and the front leg of the Scotty dog, is in profile. The corresponding zygapophyseal joint is actually closed. The pedicle, or the eye of the Scotty dog, is situated closer to the lateral vertebral body border, and more of the lamina, or the body of the Scotty dog, is demonstrated. So in this case, we can see that the pedicle here is demonstrated outside that lateral border. It's coming more towards that lateral border here of the spine, is vertebral body. So therefore, we are not sufficiently oblique. We need to get that patient into a 45-degree oblique position in order to demonstrate the projection appropriately. In the case that there is excessive obliquity demonstrated on your image, you will see that the patient is actually rotated more than needed. They're probably from anywhere from 45 to 60 or more than 45 degrees obliqued. You'll see that the superior and inferior articular processes are in profile again, which means the ear and the front leg of the Scotty dog. The corresponding zygapophyseal joint is closed, as you can see here, demonstrated in this image. The pedicles are demonstrated closer to the vertebral body midline. So you can see the eye of the Scotty dog is closer to the midline here and not out in the lateral portion of the vertebral body. And less of the lamina is actually demonstrated. This should indicate to you, okay, I'm excessively oblique here. I need to lower my patient to more of a 45-degree oblique to obtain the projection. So let's review this practice analysis of the lumbar spine. In looking over this projection, you can see that the pedicles in this projection are demonstrated. Here they are. I'm just going to put a little dot here, a little dot where the pedicles are, little dot. They're demonstrated again more to the midline of the vertebral body rather than the lateral portion. So this should automatically tell you that you are excessively rotated. We need to decrease that degree of rotation until the mid-coronal plane is at that 45-degree angle. Additionally, of course, your zygapophyseal joints will be closed and those pedicles will be demonstrated closer again to that midline of that body. Stay tuned for part 2 of your L-spine review.